This is Heart Rhythm TV, and I'm Daniel Alyesh. And I'm here today with a focused update on the state of left atrial appendage occlusion in 2025. So joining me today is Dr. John Mandrola of Baptist Health in Louisville, Kentucky. Welcome.
Thank you.
And Dr. Luigi Di Biase of Montefiore Health System, Albert Einstein College of Medicine. Welcome.
Thank you very much.
So, the premise for our discussion today is, there's a lot that's happened within, quite frankly, the last year in the world of left atrial appendage occlusion. About a year ago, we had the results of the option trial, and we are anticipating data at ACC this coming spring for the Champion AF study, which is a head-to-head comparison of left atrial appendage occlusion with DOACs. And so, in anticipation of discussing that trial, we wanted to do a focus update on where we were in 2025 with a big picture view of the evidence. Now, the structure of this discussion is going to involve Luigi acting as the pro left atrial appendage occlusion discussant, and John acting as more of the skeptic or con. And in full disclosure, I, as the moderator, I started off probably in the direction of John many years ago. I focused on VT ablation primarily, and I still do. But based upon, the evolving evidence over time, I now have retrained in left atrial appendage occlusion and am offering it in a more focused way. And so to give you a sense for the positions of everyone on the call. So it's an overview of our plan for what we're going to discuss today. We'll start with the original FDA approval, the PROTECT and PREVAIL trials. Then we'll proceed to discussing Pinnacle Flex, which is the updated version of the Watchman. Then we'll proceed to a discussion of Watchman's competitor, which is the Amulet, the IDE study and long-term outcomes, and understanding the importance of leaks, which we learned from that study. We'll discuss real-world data in the NCDR registry as it applies to acute complications, as well as understanding the importance of leaks. We'll do a discussion of leaks and DRT, and then we'll conclude with the option trial, our analysis, and then kind of projecting for our expectations of the Champion AF trial.
Daniel, if I may,
Yeah.
before you go,
Yeah.
First of all, thank you to you and to HRS TV for having me. And John is a friend. We have debated several times. We'll debate today, but at the end, at least on my side, I don't want to be perceived as I'm pro. I want to occlude all the appendage, and I don't think he wants to be the con. He does not want to occlude any appendage. I think we will discuss. There is no therapy for all patients. You have to overcome this. There's nothing for all. But in general, I think this appendage occlusion is a great therapy and should be offered to a good number of patients. We will discuss with John to which patient.
All right, John.
Fair enough. I consider Luigi a friend, and I disagree with him strongly about this. I respect him as a electrophysiologist, but I think we're wrong about this. But I will say, Daniel, that even though I think I'm right, if the new data comes out, my mind is open and can be changed.
It's a good place to be.
Heart Rhythm TV should know that I've already lost this debate on 5 continents, and so I don't expect to make any movement here today, but I'm happy to try again.
All right. Okay. So let's get started talking about PROTECT and PREVAIL. So PROTECT was the original study with the original Watchman 2.5. And I think, so one of the major concerns by the FDA when PROTECT came out was the rate of surgical effusion as well as effusion in general. PROTECT met its non-inferiority to warfarin pre-specified outcome. And then the PREVAIL trial was done after an adjustment was made, I believe, to the device in the delivery sheath to show enhanced safety, but not necessarily meeting that non-inferiority metric, but I think potentially related to sample size. So I'll start off, John, why don't you go ahead and kind of give us your overall interpretation of these original studies?
Sure. I think you're partially correct. I think, the PROTECT trial, this was a non-inferiority trial with Watchman versus warfarin in patients who could take warfarin. It was a non-inferiority, but the difference between, this stroke prevention trial and the previous DOAC versus warfarin trials was that they added a CV or unexplained death. So stroke, systemic embolism, and CV unexplained death. And I think it's important to realize that in a non-inferiority trial, when you add a outcome that's unlikely to be affected by the therapy, you just create noise and make it easier to make non-inferiority, because remember, no change is what you're looking for in non-inferiority. So, and that'll come up in the option trial. The second thing is that, yes, there were high complications in PROTECT, but it did make non-inferiority, but the problems I think the FDA had was that there were spurious signals, most likely. The primary endpoint was driven mostly by a reduction in CV unexplained death. Ischemic strokes were not different, and there was also a spurious signal of high hemorrhagic strokes in the warfarin arm. And so FDA basically said, we need to do another trial before approval. Now, of course, PROTECT AF sits in the literature as a positive non-inferiority trial, but there were concerning signals and not enough to pass FDA muster. And that's where PREVAIL comes in. Now, PREVAIL was a confirmatory trial or a second trial, and it was very similar patients. And I'll just cite the Vivek Reddy 2017 JACC paper. This is 5-year outcomes. So this is complete outcomes. And, PREVAIL had 2 co-primary efficacy endpoints. The first endpoint was stroke, systemic embolism, and CV unexplained death. And the hazard is 6.6 Watchman, 5.1 warfarin. That did not make non-inferiority. The upper bound was 2.13, which didn't even make the upper bound of 1.75. And so this is not well known amongst, I think, Watchman or appendage occlusion proponents, is that in this seminal trial, the co-primary endpoint did not make non-inferiority. Now, you might say, well, I thought PREVAIL was positive. Well, in the second co-primary endpoint, which was stroke and systemic embolism, excluding the 7 days, a proof of concept endpoint, this barely met non-inferiority. But again, whenever you exclude the procedure, you're certainly a biased endpoint. But so my problem really began when I was asked to look into these seminal trials. The seminal trials really don't show compelling evidence against warfarin. And I understand that we are doing this procedure in patients who are felt not to be long-term warfarin candidates. These patients were excluded from the trials. I understand there's been iterative developments, and so I think that's a potential issue. But the seminal trials did not show really any kind of strong signal that Watchman was any better than warfarin.
So Luigi, I'll ask you to respond.
Well, there is really not much to respond. When you decide a trial, you follow the statistical, study design and the statistical plan. This was approved by FDA. This is the way the study was designed. Every trial in medicine has some problem with the interpretation of the data, and people a posteriori will say, well, they added this into the primary endpoint. When you do a trial, you don't know, okay? And you run the trial. Some people will say, well, there is this amount of patient that, had to cross over to the other arm. But if you do the intention to treat, I mean, all of these are are, comments. In reality, these are the result of the trial. If I think about, in 2025, who would like to be on warfarin for their stroke prevention with all the limitation of the warfarin and all the limitation of being in TTR? And of course, when you start a new interventional therapy, there is a learning curve. There is an improvement of the device. There is an improvement in the learning curve. So what John is saying is not wrong, but I think the seminal trial has allowed this device to be part of our, armamentario of therapy that we can use with the patient. We have evolved from the initial, device, and I think no matter how you interpret it, this is a new option that the patient have and can use to prevent stroke, no matter how you want to interpret the data.
Can I respond to that briefly, Daniel?
Yeah, go ahead.
I think Luigi makes a strong point that no one would want to be on warfarin, and clearly, while there's been iterative improvements in the device, there's clearly been improvements in anticoagulation. I mean, we have 60,000 plus patients, and we all agree that DOAC is a superior anticoagulant to warfarin. So I think that while the device has improved iteratively, at least in safety, I'm not sure in efficacy because we'll go over that, but so has anticoagulation. And I think the other issue is that we have made this leap of faith that the signals that we saw in PREVAIL and PROTECT were enough to convince us that this device was efficacious for patients who were excluded from those trials. And I just, as a person who reviews evidence, I just find this a shocking leap of faith that we think that patients excluded from a trial that was hardly positive, was not positive, that we think it's going to be beneficial. And I think that when I was first asked to look into this back in 2018 or 2019, I just was shocked that we've made this leap. And so anyways, I think that Luigi is right that there's no perfect trials, but we as clinicians who are translating this data have to translate the data as it is, and whether we like it or not, I mean, really matter. I mean, it's not really my interpretation is what it is. It did not make non-inferiority in that most important endpoint. And it barely met in the endpoint that excluded the procedural time. So I just think it's a very weak evidentiary base to begin with.
But John, do you really believe that warfarin is superior than a device? I mean, the non-inferiority is there. It's like if it doesn't make, as if you say in one arm of the two endpoint, it don't make it. That doesn't mean that is much worse.
Oh, but I no, Luigi. I mean, when you look at the numbers, the ischemic stroke rate in PREVAIL was 6.6% Watchman, 5.1% warfarin, and when you exclude the procedure, it was 2.5 versus 1.3. That hazard ratio is 2, and so and this is the problem, actually, Daniel. I think with the whole kit and caboodle is that ischemic strokes have always been higher in the device arm. And we'll see that when we look at DRT. We'll see that when we look at Swiss Apero. It's never really been a good stroke reduction. The benefit has been in being able to stop anticoagulation, but the efficacy of this is not better than warfarin. Warfarin was better. And I suspect if warfarin was better, then DOACs would be better. Now, you can make an argument that there are patients who can't take DOACs, fine. But that doesn't mean that the occlusion device is better. than
But
nothing.
Wait, hold on,
but
hold on. John and Luigi, we have a lot of things to discuss here. Okay, so I'm gonna keep us moving here.
All right.
Yeah, I want to say one thing before we move on to our next topic. I think, John, a lot of your points are well taken. That my initial skepticism came from reading a lot of your work. Okay, and so what I'll say though too is when I look at this trial, I think of a couple of things. One is overall an older approach to everything, an older approach to left atrial appendage occlusion, an older approach to anticoagulation. What it did do was it established, I think there was always the theory of left atrial appendage as far as stroke mechanism. I think it was probably one of the strongest pieces of evidence for arguing for that. It also gave patients that had no anticoagulation option a potential option, and so if they weren't doing well. Okay, but let's move on to our next topic here. And again, we're going to continue to debate this, but I want to make sure we cover everything we need to cover. So, Pinnacle Flex. So this is a change, right? This was a non-randomized clinical trial where we took originally it was the Watchman 2.5, and now it's the Watchman Flex that it gets added into the mix here. And there are noticeable differences with regards to how the device is designed, right? Less exposure to metal. The distal tines for when you deploy the device are now atraumatic. A number of struts are different, and the ability to recapture the device and redeliver it are different. Okay. You can appreciate a difference with regards to safety events with this device. It's only in 400 patients, but you definitely see differences in safety events. There are only 400 patients there, but important points to make about this are 3 delayed effusions that occurred within the first few weeks after the device placement that were treated percutaneously, as well as 7 DRT. The 7 DRT did not necessarily translate all into stroke, but they were discovered either incidentally or in the setting of clinical outcomes. So I'll let Luigi now take the first crack on his take of Pinnacle Flex.
I mean, the Pinnacle Flex proved very well that the improvement into the device, the Flex device, have changed our practice. This device became really, really much safer to be implanted. To reposition the device has been tremendously better. Now, after this, there was a Flex Pro, but it's not part of this slide. I mean, the evolution of the device has gone, if not on the efficacy, on the safety. This device became safer and safer and safer into the procedure. And this procedure, delayed effusion were, I would say very, very rare and are very rare today. The DRT is a more complex topic because it depends also from the type of anticoagulation management that you utilize in the post-procedure. We personally, with a group of Dr. Natale, we published the resistance to clopidogrel, not even tested in switching to DAPT after 45 days of the device, and we have been proponent of low dose DOAC in the period of the endothelialization just to reduce the DRT. And it may come because of the less knowledge about the position of the device, a too distal device versus a more proximal device implant. I would say these complications that are there, we're not hiding them, have been, part of a learning curve that is getting there. So I would say this device adds that now the device is safer than before compared to the story that on the slide we have seen before. I can add a comment to the prior, since John is going to reply. How about the bleeding risk? Yeah, you're saying stroke prevention, thromboembolic prevention was not clear, but how about, bleeding and on warfarin? In the trial, people were in TTR. how many people are in TTR? How many people, eat more spinach and go on INR 7, 8 out of a trial in daily life in that trial? Now we have improved the anticoagulation with DOAC. We don't see this alteration, but as we have to compare a new device, we compare a new anticoagulant. The story is there.
John, go ahead.
So we're talking about the Pinnacle Flex trial. This is first author Carr in 2021, correct?
Yes.
Yes.
Okay, so there were 400 patients. First of all, I don't really like to call a single arm trial a trial. It's more like a study, but anyways, it's fine. The average CHED score was 4. There was a 1-year follow-up. There were 12 strokes. That's a 3% stroke rate. So since we don't have a control arm, we can use a historical control. So I have a slide. 3% stroke rates, average CHADS VASC 4. The stroke rate in Rocket AF per year was 1.7. So again, we're not seeing stroke reduction. And again, it's historical controls, but I'm just not impressed. As far as bleeding goes with Pinnacle Flex, there may be fewer procedural complications, and that's good. But at 12 months, there were 31 patients who bled. That's a 7.9% bleeding rate, major bleeding, BARC 3 or 5. And I looked it up in Rocket AF. The yearly per 100 patient years was 3.6. So again, as far as bleeding, I know it's not a fair comparison, but I don't see these huge signals of bleeding reduction and stroke reduction with this device. And I would say finally that when you consider bleeding, I mean, there's this big movement that left atrial appendage occlusion reduces bleeding. But when you look at the Holmes's meta-analysis of PROTECT and PREVAIL, and if you include the procedure, and we see this in option as well, if you include the procedure, bleeding is neutral versus anticoagulation. So I'm not impressed. I'm not impressed. I don't use the device, so I don't know. I don't doubt that it's softer and a better sheath or whatever, but the signals that we can see, that a neutral Martian can see, don't impress me.
But John, if you were one of the FDA reviewer, would you have not approved this device?
Luigi, you remember that it went to the advisory committee. It failed the first 2 times, and it made it the advisory committee, the AdCom meeting, the 3rd time was 13-12. So there were 12 people who voted against it. So yes, I would have voted against it.
Well, I mean, I think that
And I wouldn't have been alone.
we're not necessarily debating superiority or even trying to demonstrate superiority or even equivalence, right?
Well,
I mean,
you are trying to demonstrate non-inferiority,
yeah,
and
non-inferiority.
it really wasn't demonstrated. And again, I don't want to. I mean, I know you want to move on, but the non-inferiority margin in the DOAC versus warfarin trials was 1.46. And then PROTECT and PREVAIL, it was 2.0 and 1.75. So it couldn't even clear a lower bar.
But John, I mean, I get your point, but we routinely use amiodarone in patients with amiodarone proven to increase mortality in patients with heart failure. We know this from the ICD trial. So what I'm saying, it's something that if you put everything into there is nothing can be approved anywhere. So
Luigi, my friend, the difference between amiodarone and this is a preventive device for something that hasn't happened yet. Amiodarone, we're using amiodarone to treat someone with complaints with VT. That's a much different calculus than this. This is a preventive procedure, and it should clear a higher evidentiary bar.
But that's a valid point. The only other point I'll make is that when we're clinically applying the device, something usually has happened, right? Some sort of intolerance to an anticoagulant that can be at times really catastrophic, So
maybe in Colorado, Daniel, but there are a lot of patients being implanted with this device who don't want to take warfarin or don't want to take anticoagulation because of bruising or because of the potential fall. So in the best cases, this is true, but not in all cases.
Okay. All right. So
It's something. It's already something in some cases. But if you go to the trial, there are not some cases. You know, the trial was not designed for some cases, was designed as a non-inferior therapy. So we'll see where we are now. Let's go to the
yeah.
Amulet.
So we've talked a bit about Watchman. Let's talk about there are other products. The Amulet device, which is a double lobed as opposed to a single lobed occlusion device. This is the 5-year IDE results from Amulet, where we're looking at 1,788 patients enrolled in Amulet, and comparing that to 885 legacy Watchman procedures. You know, I think the important thing that came out of this study were a couple fold. One is that the double occlusive mechanism looked to be better from a leak perspective. Um, it also kind of highlighted for us the importance of understanding the size of the leaks. And I think the threshold that's commonly in the literature for saying, hey, we can stop anticoagulation in certain circumstances is when the leak is less than 5 millimeters. But a signal emerged in the data here where when you go from 3 to 5 millimeters, there clearly was evidence, peridevice leak, evidence of worsened clinical outcomes. And so, you know, I'll go to John on this one. You know, when we learned about peridevice leak and your thoughts on peridevice leak, you know, how did this illuminate your thinking, if at all?
Well, I was wondering, why is there such a strong signal of higher ischemic strokes in PROTECT and PREVAIL? Why do we see that? And I think peridevice leak is a explanation for that. So for me, it's a plausible reason why appendage occlusion doesn't reduce stroke. And I think I would compare it to the LAAO 3 surgical trial where excision and closure epicardially without a foreign body. That trial actually changed my mind about something, and it changed my mind that the appendage was an important target for stroke prevention. And I think they showed that if you close the appendage and you continue anticoagulation, you reduce stroke compared to not closing the appendage. And I think the LAAO 3 authors would argue that the reason why they continued anticoagulation is that stroke in AFib is really a systemic disease. We like to think of it simplistically in terms of just a clot going off from the appendage. But I mean, we have Virchow's triad, which shows that, which tells us that there are other reasons for stroke. So I think that peridevice leaks are a plausible reason why ischemic strokes are higher with this percutaneous closure.
Luigi, your thoughts on Amulet and your thoughts overall on our discussion about leaks?
I mean, I completely disagree with the last statement of John. Let me explain. So this study, Amulet showed to be non-inferior to Watchman first generation, and not second generation Flex. So I think the study is already updated. The Amulet can be utilized, and although they're working on the second generation Amulet because there are improvements there too. And I think if this study is repeated, Amulet versus Watchman Flex and Flex Pro, the result will be completely different. So in my opinion, the comfort of implanting the device have changed, and we have reduced the leak. Now, from this, and for John that is attached to the science and the data, from this saying that leaks are the cause of an increased risk of stroke, that's a huge statement. And I would argue that a stroke in a patient with a leak, it's for sure a much benign stroke than a stroke without an occlusion device. We have data about the severity of the stroke, and they are extremely different. I can argue with John that I would rather have an imperfect Watchman implant and have a stroke through that than have a stroke because I have no occlusion. There is no data that you can say that my stroke risk has increased because I have a leak, especially if I stay on anticoagulation. So you have a solution for the stroke. What I can say is that when there is a leak, the leak cannot be ignored, and the leak needs to be taken with attention, and you can go back on anticoagulation. And if you go back on anticoagulation, your stroke risk is for sure not higher than a patient that have no device at all. And the interpretation of the LAAO 3 in my mind is, yes, there is an atriopathy, there is a more, a disease. There are some patients that will require anticoagulation, but John is questioning the CHA2DS2. He's saying maybe that's not the right way to calculate the stroke risk. I may agree with him, but that's what we have today. I agree that patients with CHA2DS2-1, where there is no contractility or where there is atriopathy, are a higher risk of patients with CHA2DS2-5. But we cannot change medicine tonight. My interpretation about the LAAO 3 is that, yes, you have to cover the overall, more systemic disease or atriopathy. On the other hand, he's going with the assumption that surgical closure has no leaks. I can show you that the leak that we have with the Watchman are much bigger than open lobes of appendages closed surgically. I have put Watchman in patient with the clip of the appendage and with patient having strokes, because a missed lobe is much worse than a small leak or than a leak. So to conclude my part, I would say what I learned is that leak cannot be ignored, no matter how big or small they are. And the best solution is to go back on anticoagulation or low-dose anticoagulation. And this will take care also of, a kind of an atriopathy. And I completely disagree that I'm not going to recommend a Watchman, because when I have an imperfect implant, my stroke rate will be higher. I disagree with this. And if the patient ends up having a stroke, the stroke will be more benign than without a closure.
So let's talk a little bit about the real world data. And I want to make a point. These are both from the NCDR registry, okay? And I think you can talk about biases of registry with regards to self-reporting, but I think we have to believe to a degree in the integrity of the results as well. So let's talk about the leak analysis, which did bear out similarly with the 3 millimeter cutoff. You did see a signal towards increased risk of stroke. But a leak does not, I'm gonna say a leak does not equate towards an ischemic stroke. There is risk, but it's not exactly the same. The other thing I'll mention is looking at the NCDR registry. This is a paper published by Freeman in 2020, so somewhat dated, but 30,000 patients. The safety data for the acute procedure was already improved above PROTECT and PREVAIL. So they can kind of show you that we're going back in time, but operator experience matters. And they also showed that volume matters as far as improving acute safety. So Luigi, I'll ask you to talk a little bit about the real world data, your assessment of leaks and also acute safety with regards to real world data.
I think you summarized this very well. I can save some time. I mean, I think this slide speaks on its own. You summarize very well. You can see that with the ischemic stroke, the major bleeding, the death, and the adverse event are clearly shown in this slide. The improvement in the device over time with the experience of the operators and the learning curve is improving the performance of the closure and making this procedure, we are not talking about superiority, but a true alternative for many patients. Not for all patients, but for many patients.
John, your take on registries?
Yeah, I think the registry, I would not give any weight to 12 month ischemic stroke or major bleeding rates. I don't think the registry is that good, but it's surely better. It's surely better. I mean, it surely can show that procedural success and procedural complications are less. But I want to clarify. I don't think that peri-device leaks are the cause of a higher ischemic stroke rates with a device. I think it's a possible cause, number one. Number two, I would say that um, uh, that uh, uh, I'm blanking. Peri-device leaks. So I would say that there's not one observational study. There's European observational studies. There's a French registry study that all shows that the presence of peri-device leaks associates with higher stroke rates. Now, I don't know the data about disabling stroke with peri-device leaks, but I think that we can agree. And I think I even have quotes from Vivek Reddy saying that leaks are bad, and you don't want leaks because they increase the rate of stroke, and they're not the cause, maybe not the cause, but it's an associated higher risk of stroke.
Just one thing is that this registry, by the way, no matter how you interpret it, this is not a this is a mandatory registry attached to reimbursement. So people were, forced to put the data in, and we still are. So, when we look at registry and people can or cannot report, here people had to report the outcome. I think this registry is a pretty strong evidence of what's going on up until 2022.
During the time of the procedure, but you would admit that the registry weakens as time goes on because patients go to different hospitals. I mean, in our city, we have 6 or 7 different hospitals, and these strokes and bleeding may not be captured.
True, but that goes both ways, not only against the Watchman, even for patients that are on anticoagulation.
Fair enough.
Yeah. So, I think that an important point to discuss, though, is the risk of DRT. And I think this is a review from 2023. And Jack, just talking about the risk of DRT, you saw in the original Watchman Flex, with an improved device, there were still 7 DRT. Not all of them equated to strokes, but it is of concern. And now there's Watchman Flex Pro, which supposedly has a coating that can reduce risk of DRT. However, that needs to bear out over time, quite frankly. So, but I want to, talk a little bit about what is our understanding of DRT. DRT does exist, right? And we have mechanisms for trying to predict who gets it. It typically equates to a sicker patient, which is probably going to be a better candidate for a Watchman as well, too. If you look at, higher chassis vascular dysfunction, more advanced AFib, renal disease, et cetera. Implantation technique also matters, right? You try not to implant the device too deep. And I think that's true. Luigi made the point of doing a good job clipping the appendage, right? It's all about the quality of your result and not leaving a stump. And so I think that's also a consideration. Also, the way that you anticoagulate after the procedure while it endothelializes is also a consideration. I'll make the point, though, that post endothelialization, there are evidence that the DRT does still form. And so, I'll open up our discussion to talking a little bit about DRT. What is our thinking? How does this influence our impact on using this with patients? And I'll start with you, John.
Well, I was hoping we would talk about Swiss Apero, but I'll just bring it up. I mean, Swiss Apero was Amulet versus Watchman in Swiss hospitals, published in Circ 2023. They used CTA to look for patency of the left atrial appendage. And I think the most striking finding from this study was that 50% of the appendages were patent. That means that 50% were not patent. Now, you think, oh, well, CTA is more sensitive, but I have a quote from Vivek Reddy. If one defines leak on TE as any atrophy space, then the incidence of leak will be similar to CT, and they're both bad. So in some ways, I guess you can look at this as a little disappointing and depressing because that means we have a lot of leaks. So I'm not saying that a CTA leak is the same as a TE leak, but again, I guess the take-home point is that it's really hard to close a left atrial appendage with a percutaneous foreign body. And there'll be iterative improvements, but 2023 data shows that 50% of the time it's not closed in a trial.
We'll get to Swiss app. Luigi, why don't you give your
Well,
opinion?
DRT are a concern. Are probably, to me, if I have to think about what the biggest concern is, DRT. As you said, technique implant over time has evolved, and now we know what can we do. Don't implant the device too deep, and the introduction of a deflectable sheet has improved also our ability to close the appendages at the level of landing zone that we prefer, and that has come over time. Plus, we have some patients that are sick where the chart vasc don't apply only, and they still need a load, some form of anticoagulation. So I still believe that the combination of a closure device and a low dose of anticoagulation in some patients is necessary. We have improved. I think this DRT will go down with the new technique implant and with some new development of the device. Right now, it's an issue, and we need to follow up. Now, in regards to how to detect the DRT and leaks and flow, well, the learning curve is not only for people that do the procedure. The learning curve is also for people that interpret LA closure device either with TE and with CT. I have example of follow-up of patient that I've been told there's a clot at the tip of the appendage, there's a clot behind the device, there's some flow through the device in the first 45 days. I mean, all of these are examples that even the operator reading the CT scan need to be experienced to assess leaks and clot. And having a clot in the back of an appendage is actually a good thing. It's not a bad thing. It means you have a full occlusion with no leak, because that's why you have a clot. So I would say this is an issue in medicine where when we analyze the data needs to be equal for everybody. And the interpretation of CT scan of LA closure require a learning curve, and the data are a little bit mixed leading a point. The interpretation of leaks require a learning curve. So I think we need to put things together, and we need not only to say how the assessment was done, but by whom was done, which type of experience, which type of protocol. So it's very complicated to assess all of these things and put them into a full consideration.
So thank you. So, a point to make about Swiss Apro, because John brought it up, I think that the data for leaks and that were higher than what we see in other pieces of literature, maybe for various reasons. One is, I think they did their CT scan at 45 days. Was the device, was there more work to be done to further assess the leaks, leak through the device, peri-device leak? I think you can draw critique in their timing and then their lack of reassessment, as well as you can talk about the learning curve for assessing the leak. The other point that I'll make, and again, I'm going to acknowledge that Swiss Apro did not look good for left atrial appendage occlusion, but is also that the Amulet device is probably 4% of the U.S. market, so not necessarily reflective of what's happening here in the United States. But you're right, we need to understand what's happening globally.
And the device has been changed. They now have the new Amulet 2, and the comparison was with the third generation Watchman. This is important to be said.
All right. All valid points. So, this is another, this is a JAMA Neurology paper that came out, I think about a year ago, where talking about a different strategy. Now, I think this is maybe where we can come together, but maybe not, where we say, hey, this is a patient who has had a stroke. and in this case, it was DOACs. So a stroke on anticoagulation, occluding the left atrial appendage and continuing the anticoagulation. So this is another example of, the left atrial appendage as a contributor to stroke in the setting of atrial fibrillation. Now, John's point of Virchow's triad, and we can't be so simplistic about thinking only about the left atrial appendage. There's validity to that, but I do think that mechanistically there are relative contributions, and maybe the addition of the appendage occlusion to systemic anticoagulation is valuable. Now, this study here, just to give you a sense for the design of the study, it is about 800 patients. These are prospective. It's a prospective registry with propensity matching. Okay, so it's not a clinical trial. It's not a randomized clinical trial. I'll turn my first question to John, your interpretation of these data, adding left atrial appendage occlusion to anticoagulation for those that have had a stroke.
Well, Daniel, I mean, I wasn't actually familiar with this paper, probably for good reasons, because it's a non-randomized comparison. So a clinician chose to do this. And the fact is that the left atrial appendage arm looks a lot better, but it looks better in the first week. So there's immediate separation, which whenever you see immediate separation of an ischemic stroke or some event that's supposed to happen over months to years, when you have benefit within 2 weeks, then you know that they just picked healthier patients for that. It's totally confounded. You can't make anything of this study. So I would completely discount it. Sorry.
Luigi?
Well, John likes to see only what he likes to see. The paper that don't support this idea, he doesn't read. It's another piece of information. I agree. It's a non-randomized study. It tells us something. Why the curves separate there can be, the effect of chance, or it's something happening for real. I don't know. This is the data. I think in patients that have ischemic stroke, looks like the occlusion is doing something very positive, and we take this piece of information. I'm not going to change my mind and say, oh, that's extremely good for the closure, but I'm not gonna say that it's a bad study.
Okay, so moving forward to I think this study, the option trial, definitely it was a very interesting study comparing 1,600 patients that underwent AFib ablation and then received continued anticoagulation versus left atrial appendage occlusion. I think there are important points to make about this trial. One is that event rates were much lower than predicted. And so the statistical power to, what it was powered to do versus what it actually ended up doing is a question. But, there was non-inferiority with the primary efficacy endpoint. And then if you look at the next slide, when you did not include procedural bleeding, there quote unquote was superiority. Now, that being said, if you include the procedural bleeding, then there again is a similarity between groups. I'll start off with Luigi, your thoughts on option trial.
I think this is a great trial. For me, unless we change the guidelines, post-ablation, the guidelines quote, irrespective of the ablation outcome, patient should be on anticoagulation as per the stroke risk profile and CHA2DS2-VASc. This is what they quote. I'm an author of it in 17 and 2024, with or without disagreement that I cannot disclose right now. All I know is that this trial allow me to offer my patient the option, as the trial say, to say, listen, with or without my successful ablation, your CHA2DS2-VASc score is 4. and you have to be on anticoagulation for life, or we can do a procedure that is the occlusion, which has possible procedural complication, possible risk of DRT, possibility of having a leak in the 3% rate, but in 90% of the time, I will be able to stop your oral anticoagulation for life. And I think all patients need to hear that they have an option.
So this is what I talked about with regards to clinically relevant non-major bleeding. John, I'll ask you your interpretation. I've read your interpretation, but your understanding or your opinion of the option trial.
Yeah, I think it's one of the worst trials we've had in electrophysiology in a decade. Really, I've never written about a trial before I knew the results, but I wrote about option because I predicted every result. So, it's a great idea, Daniel. I think it's a great idea, but you could have known that stroke rates were going to be low, and if you wanted to show non-inferiority, then you have to have enough patients. The DOAC versus warfarin trials had tens of thousands of patients, so you're not going to be able to do it with 1,600. And so adding death to the primary endpoint is even worse than adding CV deaths, because we already know from the LAAO's trial that even with the reduction of stroke with appendage excision, it didn't have any effect on death, and that's because there's so many more reasons to die. So you just add death to the non-inferior endpoint, so you can make, you can have statistical power, but it just makes noise. The incidence of stroke was like 1.2 and 1.3%. So if you were going to show a non-inferiority of that, you're going to need way more patients, and to just create a trial that has nowhere near enough statistical power to show a difference is really, I think, is really bad. So that's on efficacy, and of course, I think it's just completely pseudo-scientific to exclude the 7 days of the safety endpoint of bleeding. I mean, a patient can't exclude that, and we're clinicians. Bleeding is bleeding, whether it occurs in the first 7 days or not. And so, had they included the bleeding around the procedure, then there was no advantage, which is of course what we know from the meta-analyses of the Watchman versus warfarin. So I think that the idea of adding appendage closure to AFib ablation, I just don't think you can take any clinical translation from option, and I think it's really a sad day for EP that this was published and interpreted as it is.
So,
But, John, come on. This is a randomized controlled trial published on New England Journal of Medicine with a strong statistical methodology. You may say it's not enough. This is not for all patients. These are for patients undergoing ablation. We have been questioning the other two trials. This is for patients undergoing ablation that have an age of 70 and a Charles score of 3 or 4 that have to be for the rest of their life on anticoagulation. And we are not saying do the closure because you are going to do better. We are saying give the patient the right to choose how they're going to continue living their life. We're just giving an option. We don't want to be better. We want to be equal. And I don't think this trial don't give you that message. The patient have the right to choose how to die, on an anticoagulant or with a Watchman. And to me, there's no difference.
Well, we just disagree, because if you have stroke rates of 1.2 and 1.3%, to say that something is equivalent, you're going to need a lot more than 1,600 patients. And we're going to, it just defies science to say that these are the same with this kind of data. I mean, it's not right, Daniel. It's not right.
So I want to ask a couple questions about this, just because number one is, your point about death. Okay, so at least my understanding of stroke related to atrial fibrillation was that there were larger strokes with significant morbidity and mortality. But your point is that the data show that that mortality is not enough linked to ischemic stroke with AFib to make it valuable. Is
Not
that
even close. Not even close. The population attributable risk of stroke and death and contribution of stroke to death is really small. I mean, it's like 10% or less. And so these patients who are in their mid 70s who have AFib and hypertension and diabetes and all kinds of diseases, um, I mean, reduction of stroke does little to move the death signal. And of course, that was confirmed in LAAOS. I mean, I think LAAOS was like a 30% reduction in stroke, and it had no effect on death, which is exactly right. So when you add death to a non-inferior endpoint, you're just adding endpoints that are going to be the same in both arms. And by doing that, you just make non-inferiority easier to reach. It's I really want to bite my tongue because it's really cynic. It really makes me cynical about the scientific enterprise because it's just not right.
so? I hear your point there. So the next point, the next question I have for you is, um, one of the points or one of the things that we're seeing in this trial, amongst other post-ablation trials, is lower event rates. And I believe you quoted a little over 1% risk overall for the stroke rate. But if I remember reading correctly, it's less than 1% per year in the study. Um, and I'm turning our discussion a little bit because of the original adage of arrhythmia burden doesn't matter. Okay. And we see in this study, as well as alone AF, I don't know if you're familiar, I mean, I know I'm changing our discussion about alone AF, where we look at it,
Right.
arrhythmia burden, and then now alone AF is a slightly lower risk population, but when with a successful ablation, the yearly stroke rates are equivalent to those without atrial fibrillation. You can make that argument. So I want to ask you, John, what is your interpretation of a fib burden and ablation on stroke risk?
Right. I think that this is the point. If you go into the supplement of Cabana, you'll find that in Cabana, the post-ablation stroke rate was like 2 or 3%. So stroke rate post-ablation is very, very low. And so rather than rather than put in a percutaneous device that has a risk of peridevice, and device-related thrombus, you could just take the patient off anticoagulation. And of course, because the stroke rates are so low, you're going to need a lot of patients, and you're going to need a long follow-up. And this is going to be the problem with the Ocean trial that's coming out at AHA, is they're going to look at successful ablation and stopping anticoagulation versus continuing it. And I think that what they're going to find is very low stroke rates and wide confidence intervals, and that's what we saw. If that's what you see in option. And so for me, rather than put a device in, if you have a successful ablation, just follow the patient and then you can stop the anticoagulation. And a proper way to scientifically answer this question would be to have 3 arms and to randomize enough patients. And now you might say that's impossible, but to me, you just, yeah, the low stroke rates are a positive, but that doesn't mean we have to put in a appendage closure device.
I mean, I don't disagree with this. A study with 3 arms could have been done and can be done. All we know is that we know ablation doesn't have 100% success rate, especially over time. And we know which patient most likely will recur. We know which patient most likely have an increased risk of stroke rate. So I start the conversation tonight. This is not for all. If you have a young patient with paroxysmal AFib, Charles VAS score of 2, I believe that this patient could and can stop anticoagulation after ablation. But in patients with chart VASC of 3, 4, with persistent AFib, with other comorbidity, with risk factor not present into the chart VASC, like atrial contractility, appendage contractility, and others, I believe the rate of recurrence and the stroke risk is that high, and this patient need to have a stroke prevention therapy, and they need to be given the option to decide if to do that with a lifelong therapy with a drug or with an occlusion device. They are both non-inferior, and people need to have the right to choose.
Okay, all right. So I'll take us to our, our final discussion topic. We're preparing for, the next big release of evidence with the Champion AF trial. I think to come out at ACC this coming spring. 3,000 patients with a chassis VAS score greater than 2 in men, 3 in women, randomized to the Watchman Flex versus DOAC at 142 sites, followed for 5 years. DOAC, aspirin, DOAC alone, and DAP for at least 3 months post-implant versus a control group with DOAC. So I'll start off with John. What do you want or need to see from this trial to influence or impact your thinking?
I'll say that Champion AF is a reasonable trial. They have the same endpoint. The primary endpoint, I looked it up, a composite of stroke, cardiovascular death, and systemic embolism compared for non-inferiority. So the first endpoint will be the same as PROTECT and PREVAIL. It's not ideal, but it's okay. Non-procedural bleeding, that's the problem, right? So it's going to be non-procedural bleeding as the safety endpoint. So they're going to exclude, they're going to be very similar to option. They're going to exclude the procedure, and that's really going to favor the device. And the third non-inferiority endpoint is stroke and systemic embolism. So that's going to be an important endpoint. It's a 5-year study. That's good. But I guess the main thing to look at would be the safety endpoint, including all bleeding. So we'll see. I think it's going to be underpowered because 3,000 patients isn't enough, but we'll see.
Luigi?
Well, I think I'm going to ask John, do you think this study has power? I mean, is enough patient or not enough?
No, not enough. Because first of all, temporal trends so that stroke rates are going down. So we know stroke rates are lower. We know that the DOAC trials had 10 to 18,000 trial. So we're going to have 1,500 in each arm, and I think it's going to be underpowered, and there's going to be high uncertainty intervals. But then, Daniel, the problem is it'll be interpreted as non-inferior, and then we'll have folks saying you have an option to take this device or DOACs, and we won't have answered the question.
Well, I say it's a trial with all its limitation. Again, non-inferiority outcome will have to be looked, inside in a deep way. I agree with John on that. On the other hand, if you have AFib and you go to a cardiologist, they put you on a lifelong DOAC. And this is the only thing we can have. Is it safe to get 30 years of Eliquis or Xarelto or, all the other drugs that we do have? Or can our patient do something different? Maybe this is not enough, but you can't say that you have to be taking that medication as the only option for your life. And we know, on the other hand, that if you believe that that medication is necessary to you, it's hard to be compliant. Patients become old, have a fall risk, got probably with their memory. They don't have social education to understand the relevance of compliance. So if you believe that somebody needs to be on that medication for life because of the stroke prevention, then give some of these patients the option of something else. Not all the patient, but some patient really benefit because the blood thinner for life, it and will be an issue.
Yeah.
It makes me smile, Daniel, that Luigi has a time machine and he can tell what's going to happen at day 7. And it's funny. It's funny. He has a lot of faith, more faith than me. I think that we really, if we're evidence-based practitioners, we have to include the time of the procedure. But I want to finish with agreeing with Luigi that I think lifelong anticoagulation, more and more, I find myself stopping anticoagulants in patients who no longer have AFib, and loop recorders, Apple Watches, smart devices have really, I think, changed the monitoring. We now know that short duration AFib is not as risky as clinical AFib, so things are changing. And I don't think one diagnosis of AFib commits you to an anticoagulant for 30 years.
All right. Well, I think we had lot to look forward to. This has been a really great discussion. Great points on either side, and we look forward to the results of the Champion AF trial and Ocean trial and others coming forward. Thank you both for joining me.
Thank you,
And-
Daniel, for having
Yeah.
us, and thank you, John, for this other debate. We can think different ways, but we both care about our patient, and we both care about medicine and science, and always a pleasure. I think you grow up when you just don't just digest stuff, and you try to look into it, and having a lot of eyes around us is always good.
And I'll just say one final thing. The debate has to be in the open. That's why we had it. We can disagree and we can learn. So, I appreciate you all joining me, and thank you
Hey,
all for
all
tuning in to
right.
Heartland TV.
Good night. Thanks, Luigi. See you later. Bye-bye.
Bye bye.